Okay. I will ask the first question, and I may ask one or two throughout the thing, but I'm gonna move the audience pretty quickly. So be thinking of what you want to ask these guys. To start us off, my question is about. I'm making up this terminology. I don't know if it's real terminology or not, but consistent, non-standard responses to psychedelics. So, for example, MDMA typically produces a lessening of anxiety, a kind of opening up, some empathy, a kind of expanding in forgiveness and things like that. But as we often hear in the psychedelic community of people who respond a little bit differently, maybe with more agitation rather than less, or maybe a little bit of anger, or maybe they have some depression or something like that that kind of gets thrown in there and produces a sort of atypical response. And I'm wondering, 3 different perspectives, okay? I'd like to hear a little bit about what's going on in the brain when that happens, okay? And I'd like to hear about whether these kind of Apollo technology that does this mechanically can get around some of those non-standard states, or if they happen there too, if you know that, or if you have even a guess about it. And then I would like to hear Rick talk about how this has, if any, implications for policy concerns. Does this factor into what the FDA wonders whenever they're asking you if this is okay and things like that?
Who do you want to start?
We'll start with Cool.
Okay. All right. Well, mine's going to be probably the most boring answer, but I talked a lot during my talk about the serotonin transporter as the main mechanism of action, but actually we know that MDMA, the kind that you typically would find on the street, is a racemic mixture. It's got 2 compounds in one, so they're mirror images of each other. They look very similar, but sort of like your left hand and your right hand, they're not identical. And the 2 stereoisomers have different binding affinities for the serotonin transporter and then also the dopamine and norepinephrine transporter. So the DAT and the NET, they were also on that evolutionary circle. They're related. Those 2 are more closely related to each other than than they are to serotonin. And it seems like some of these negative effects potentially of, causing motor agitation or sort of the gnawing jaw stuff, that there's some work from Leonard Howell's group actually at Emory that has looked at the stereoisomers and found that most of the prosocial effects are all on one isomer and then the negative motor effects are on the other. And in fact, we have a little bit of preliminary data, just a little bit, not for publication yet, that we can reopen the critical period with one of them and not the other. And so that's really exciting for the future because, it's potentially something that, you guys, I assume, are looking into. But anyway, we haven't followed up on it yet because it's turning out to be just a little bit more complicated than we had hoped, because it turns out that when you have compounds that are mixed like that, the dose response should be very easy to calculate, and it's not turning out to be that way. So we don't really have a handle on what's going on. So it's going to take us some more time to figure that out.
So you think maybe MAPS is going to start offering 62.5 milligrams?
No, so that's the problem, is that we would expect that if we gave just the one stereoisomer, that we would be able to change the dose to reflect the fact that now we were giving a more pure substance. But we haven't actually seen that. We're having to give the same amount as if it was a stereoisomer, which suggests that our usual way of thinking about the pharmacology isn't quite right. And we've had so many other things going on that I just haven't sat down and tried to think of what to do next to solve that. So
That's a tough question.
Well, let me respond, though. About 30 years ago, we tried the different isomers of MDMA.
Okay.
And neither of the isomers was as effective that we thought in therapy as the racemic mixture.
That's right.
So we've sort of given up looking at the isomers and see no point in it.
But what we're saying is that we saw exactly the same thing, but if you give the isomer at the dose, double the dose essentially,
right,
then it works perfectly, and there's none of the other side effects. So at least in our hands. So
really
it's
interesting.
weird. It's not typical pharmacology. It's not what we learned as pharmacologists, and we have no explanation, which is why I'm not publicizing it. Well,
no,
except that I just
yeah,
told everybody.
okay, it's really interesting. But we did do all different doses too.
Okay.
Yeah.
All right.
And so it just didn't seem like, regardless of the doses, that the separate isomers, either one was better than the racemic mixture. But it wasn't like a systematic study.
Yeah.
It was just a bunch of very experienced people
Right.
giving it a try. We've also done the different isomers of ketamine. And, now as ketamine is a medicine, the main benefit of that is that it's patentable. I don't think
Yeah.
that it's any better than the racemic, or I think it's
Right.
not as good.
But the MDMA is not patentable, right? Because NIDA gives out the stereoisomers for free.
Oh yeah, it's
Yeah.
long.
Well, it was,
yeah.
But you
long
could
out of
get a
patent.
use patent
Yeah.
potentially, but it just the side effects. Because I heard your question kind of in a different way. So that the jaw clenching, things like that, those are an issue, but they're not a significant side effect that we need to do much about. So I guess I heard you about people that have panic reactions or or fear-based reactions or things like that to MDMA, and that does happen. But it's more about the environment that people are taking it in. And so, as an example, years ago, we had 1 week we had 2 women contact us with very similar stories but different outcomes. Both of them had taken ecstasy at a rave. And both of them were with a group of people that they were trying to have fun with. And both of them had remembered prior sexual abuse. And so one of them said that she was with a bunch of friends who only wanted to have a party, that she felt that if she were to talk about what was going on for her, that it would bring them down and that they didn't want to hear it. So she stuffed her feelings. And this was months later, she felt worse. So that the actual MDMA experience made her worse. It didn't help her resolve the trauma because she felt like she couldn't really share it. The other woman said similar story, but she was at the party and she went off to a corner with a girlfriend of hers and talked about it. And after an hour, she worked through it. She went back to the party. She felt great. And months later, now she felt better. So I don't think it's a product of the drug so much as the context. Another story was we worked with one person who, this was when we were experimenting on a beach in California, and it was a German doctor, and his arm became paralyzed under the influence of MDMA.
Wow.
Completely paralyzed. And so we knew that this is not from MDMA. MDMA doesn't cause nerve damage like that. If he would have been with people that didn't really understand that, it might have been a horrible thing. He might have gone to the emergency room, but we said, let's just talk about it and see what happens, what's psychologically behind this. And so over time, he told this story about how he was involved with his mother and his siblings and this decision of whether to take life support away from his father. And that since he was the doctor, he had to write the order and to take life support off of his father. But the problem was he said he hated his father. And so this was this conflict. Did he really kill his father? Was it out of hatred, or was it something about what his mother wanted? And so over the course of several hours, he started understanding that his mother wanted it, his siblings wanted it. It probably was what his father wanted it. And even though he did essentially kill his father, that was not out of hatred, but it was out of this everybody's compassion. And then the feeling started coming back to his arm. So at the end of it, he was fine.
Wow.
So it's how you react to that kind of stuff, and so much comes in the body first before you can. If it's too complex or too problematic for you to think about it, it'll often come in your body first. And so we work through body pains, and then you get stories, and then you eventually get, hopefully, resolution.
Yeah.
So that's how I heard your question, and I think it's more about the context and how we need to offer support to people.
Yeah, I completely agree with you, Rick, I think, and also with you, Gul. I think I also heard the question the same way, in that, what we see sometimes is very unexpected results when we give somebody MDMA or we give somebody psilocybin in what we consider to be an extremely safe environment. And then even in psychotherapy, sometimes this happens, but when you're in an altered state, some of these things from the past that maybe in your lifetime, your past, that you are consciously aware of, or it might be birth trauma in some cases, as Don Groff talks about, or it might be something that happened to one of your ancestors that will surface in some strange way, like an arm paralysis from MDMA, which is not a medically related issue, but it's a trauma related issue. And what happens is that when you curate a safe experience for people in a very specific, in a way that they feel comfortable allowing that stuff to come up, sometimes it just comes up and they don't even realize that it's coming up, and it comes up in ways that are very much unanticipated. And Bessel van der Kolk talks a little bit about this in The Body Keeps the Score, which many of you have probably read, but it's just an interesting idea about how when we experience trauma or we experience anything and we don't process it, then we store it away in our bodies, and eventually it comes back in one way or another. What we've seen with Apollo is that Apollo has the ability to reduce some of the anxiety around these kinds of states. So when people have been under the influence of MDMA or psilocybin in particular, we see in some self-reports of LSD, we see that people, when they start to feel anxious or feel like something uncomfortable is coming back, then they can use the balancing energy of the Apollo through the skin to feel safe. And it's very grounding, and it helps bring people back to a centered place where they can more comfortably approach what it is that they're feeling that gets surfaced from the trauma. And so unfortunately, we haven't done studies with it because it's very difficult to do, and these are all anecdotal reports. But we see consistently that when people have profound discomfort or anxiety or the resurfacing of trauma in these situations, where psychedelic medicines are involved, that by giving them something that they can control, that they can turn on and off, that helps sort of regulate their energy and their mood a little bit, it's very empowering in that state to help people feel calm. Because trauma in a lot of ways is this, it's this injury that happens to us where control is just ripped out of our hands, and we just don't feel, empowered to control our symptoms or the situation in a lot of ways, and that happens over and over and over again. And so and we do this a lot in therapy, even without assistant tools like Apollo or other devices, by holding somebody's hand, doing body work, helping them move around, or giving them soothing music, or guiding them through a breathing process, you can help them sort through what comes up and what's surfaced. And then they can go back and party or go back and hang out with their friends or whatever it is. But when those things come up, it is really important to address them. And also, as somebody who provides therapy to people, it's really important to anticipate that these things could potentially come up at any time in somebody that you're working with. So always be extra, extra careful that you have everything you need with you in terms of tools and resources to help somebody, calm down and de-escalate and work through what comes up when it comes up, because you don't know what's going to happen sometimes.
Yeah, and Bryan, you had the policy question aspect of it. So I'd say the main policy things that we need are, first off, honest drug education. So that people don't say, oh my God, I've got holes in my brain now, or this is really hurting my, I'm going to be paralyzed or whatever.
Right.
Their minds will go to all sorts of different things. So we need honest drug education. And then the second is that we need harm reduction at festivals and all over the place, so that it's not seen as a vulnerability from the festival organizers, that now they know drugs are being used and they're offering harm reduction services, therefore they could be prosecuted potentially by police authorities. So we need to change that around so that the promoters of various events are almost required to have harm reduction, just the same way that they're required to have medical staff in case there's something. And then the other part is drug checking, which can also make people get nervous or freak out. And more we're seeing fentanyl put in other things, even MDMA occasionally. So we need, before we get to post-prohibition world, we need drug checking so people know what they're taking. They get opportunities to get help if they need it, and honest drug education. And then I think these atypical reactions will be mitigated, and that's the policy prescriptions.
Okay, yeah. Dr. Farkas.
Hi. Can you hear? Yeah.
Yep.
This is a larger question than focusing on something quite specific and practical, I hope. Given the extraordinary polarization of this country, and the prism that I see this through is the conflict between appealing to the amygdala versus the neocortex. And in a contest for hearts and minds, in which one side, as a side, intentionally, cynically, weaponizes appeal to amygdala and limbic forebrain. The other says, come, let us reason with the evolutionary Johnny-come-lately 2-millimeter thick neocortex. The neocortex does not have a prayer of a chance. So my practical question is this for all of you. In order to do impeccably rigorous, basic, mechanistic science translation, as well as getting this available for real people in real situations, all of the medical issues for which psychiatry and society have so pathetically little, whose magnitude of suffering is so extraordinary, treatment-resistant depression, addictions, PTSD, etc. What has been your experience in identifying people who are of the amygdala sort, who have personal, family, skin in the game, suffering from medical issues that these kinds of approaches would mitigate and perhaps allow them to see some light and open a pathway?
Right. Well, we have a senior retired DEA official who is acting as a consultant for us, which has been tremendously helpful. We've had meetings at DEA headquarters. He's facilitated people getting Schedule I licenses, and it turns out that his son enlisted in the Army, went to Iraq, and has PTSD, and now has come back and uses cannabis to help him PTSD. And that changed the mind of the father, and now the father is acting as a consultant for us. Yeah, no, he's not. And sadly, what you see is that a lot of people who have the sort of fear-based drug warrior kind of thing, when they have somebody in their family that needs help, then things change. Mm-hmm. And so I think it's again, it's not a rational thing, but it's like emotional bonding. And so I think we need to move forward in kind of working with the military, working with police. So we have now a police psychotherapist who is a full-time police officer who's going through our training, and he wants to use MDMA with other police officers. So I've become aware of how many police officers are committing suicide. The police are actually preferentially supposed to hire veterans. So you get veterans who are traumatized, and then they come in, they're a highly traumatized job being a police officer. And it turns out that most police, or many police, at least I was told it was a majority, that are involved in shootings become alcoholics, that there's an enormous amount of suffering there. So I think that we need to really move in those directions. And one of the reasons why I think that ibogaine is sort of the next priority for research for opiate addiction is because there's a bunch of sociologists who've looked at what they call deaths of despair. And so those are suicide, drug addiction, and overdoses. And so in those counties in America where there is more deaths of despair, there's higher voting for Trump. So how do we both help people who are despairing that their culture is changing, their jobs are leaving, automation is doing this and that? How do we help them both cope with that and spiritualize them? And so I think ibogaine is sort of designed as a tool to reach out to those people who you're saying are amygdala motivated. And the last thing I'll say is that a lot of people say, let's just give MDMA to Trump, and that'll be better. And so what I've learned from my psychedelic experiences and my sort of encounter with the inner Hitler, and sort of I've had various experiences with observing Hitler give a speech and all in a ketamine session. Basically, the idea is that people have to want to change. So when we talk about how we are empowering people to heal themselves, if somebody doesn't want to change, they're not going to. So I think paradoxically, rather than giving MDMA to Trump, what we need to do is give MDMA to the millions of people that give away their power to something like that. So what we need is mass mental health as the long-term solution, which is why medicine is only a stepping stone towards a post-prohibition world and embedding these sorts of experiences in our culture.
I love the last thing that you said, and I think that the reason that I find that to be so compelling is that I find that, you know, while I do think that these drugs have incredible healing potential, we need to be careful, because if you reopen a critical period, for example, and then you just have somebody trot down the same rutted path that they have always trotted down, you're not going to induce the change, right? And I think that's sort of the mechanism. And why I think these drugs are so exciting is because, unlike other attempts in the past that have tried to reopen critical periods, which were just like ripping apart anything that was stabilizing the synapses and crystallizing those memories, these drugs, because of this exact feature that you actually have to be focused in on the change that you want to have happen, are a sort of surgical way of manipulating memories and learned experiences only to be altered if you focus on them. So that is both a plus, so that, you know, if you have a critical period reopened, you can, you know, unlearn the traumatic memory without losing your ability to speak French, for example. But it also means that, you know, they do lend themselves, these drugs, to what I call confirmation bias. So if you take one of these drugs and you already believe in God, then you're likely to leave feeling absolutely certain that there is a God. And if you are a neuroscientist and you take one of these drugs, you leave feeling absolutely certain that we are made up of neurotransmitters and chemicals and receptors, right? And so I think, you know, we have to be careful, both because of the confirmation bias issue, but also in realizing that what Trump has been saying about giving out intranasal MDMA to all of the veterans. Oh, ketamine. Okay. I don't think that's the right approach, because you do need this reformulating your history and your memories and taking on a new pathway. So that's what I think.
I couldn't have said that better. So all I'm going to say is the age of the amygdala is coming to an end.
Or else we're coming to an end.
Yeah. Yeah, I will say that, actually, you reminded me that for all of you who haven't seen Rick's TED Talk, it is really phenomenal. And Rick ends this TED Talk in a way that I haven't heard anybody else end with a call to action, which is this really incredible idea of a description of the situation we're in. We're in this world where we're all now faced with a choice between consciousness and catastrophe. And we know what inaction and apathy lead to. It's not that not making a choice is any better than making a choice to do the wrong thing. They're really one and the same. And when you really look at the scale that we're facing right now of issues in the world that need to be solved, it really is a choice between consciousness and catastrophe, and it's up to us individually to each make that choice independently for ourselves and then reflect that out into our community. And the amygdala and catastrophe really like each other.
So just tagging on to the last thing that you guys said, I wanted to ask your personal opinions on this research coming out of Yale with Dr. Ben Kilmindy, and like what you guys think the implications will be if you see enormous changes in people's like symptoms in the minimal amount of treatment as possible, and what that means that MDMA is actually doing. And what like the real mechanisms of actions or change are in a situation where there's almost like minimal treatment.
Well, I'll say that in our phase 3 study, where we have 3 MDMA sessions, 1 month apart, and 12 90-minute non-drug psychotherapy sessions, 3 before the first for building a therapeutic alliance and preparation, and 3 90-minute sessions after each one. We see the greatest decline in the PTSD symptoms after the first session. And I would say it's more like 60% of the declines are after the first session, another 20% after the second, and another 20% after the third. And these are, again, on averages. We have some people that have said after their first session, in fact, this was the person I talked about in my TED Talk, there was someone who, after his first session, he said that he realized that he had benefits from having PTSD, and that was how he showed his loyalty to his friends who had died. And as long as he was suffering from PTSD, he was being loyal to their memories. And he looked at himself from their eyes, and he realized from their eyes that they were dead, they couldn't live, they would want him to live, that the better way for him to honor them was to live as fully as he could. They could live through him that way. And he said, all right, what am I going to do with the rest of my life? And at that moment, he cured himself of PTSD. And then he said, I'm on opiates for pain, but I really don't think I'm taking them for pain. I'm taking them for escape. I don't need opiates anymore. I don't need any MDMA anymore. I'm dropping out of the study. And a year later, no PTSD, and that was over 7 years ago. He still has no PTSD. So I think some people will be able to get better after one session. We do also see that people go deeper and do the deepest work on the second session. So the first session, people are getting to know the therapist, getting to know themselves, getting to know MDMA. They're learning that this stuff which is previously so painful that they've suppressed, that if you bring it to the surface, then they can process it. And then the second session, they're even doing deeper material. So we may find from Ben Kilmendy's study that some significant fraction of people are able to make major progress after just one session. However, the question is that durable? How long does that last? Have they learned enough? And so we think the standard model going forward will be 2 sessions, not one, and that the third session will be for those people that need a third one. Sometimes people with personality disorders or high on the dissociation scale, or people that have only recently tapered off of SSRIs seem to need more sessions. So I think that'll be available. So we already know that most of the benefits come after the first session, but that we believe that for long-term sustainability of the benefits and for this deeper anchoring, the second session makes sense. But it may very well be, we're now working with chronic, so far we've worked with chronic treatment-resistant PTSD. So if we can treat people closer to the trauma, and this also relates to adolescence, if we can treat people closer to the trauma, maybe they only need one session. Like the ski slope that you sort of slowed, that once they've had PTSD and it's been there for 15 years or whatever, it may take more to move them onto a different kind of a slope. But for those people recently traumatized, maybe just one session. So we'll see, how insurance companies and others handle that. But what for me would be this idea of more moving from veterans to the Department of Defense, moving from adults to adolescents, or in general moving, not waiting for people to be chronic treatment-resistant PTSD, but treating them earlier.
In that study with Dr. Ben Kilmendy, is it chronic PTSD?
These are people that have had chronic PTSD, yeah.
All right, we're gonna take one more question, and she's had her hand up for a while. If we can have her.
Just one more?
Well.
Oh, Bryan.
Yeah, we gotta go. We gotta set up for artists and have a really good party in about 40 minutes.
Okay.
Last question right there.
Hi, thank you all for your talks today. They were amazing. My question is, speaking for myself, surviving the Nancy Reagan years growing up and then the indoctrination of a medical education, residency, and then a decade in the Army, it took waking up from someone in my family having a medical condition to realize the benefits of medical cannabis. So in light of that and the fact that we have the highest rate of suicide in any other profession, have you given any thought to centering in on healthcare providers, physicians, nurse practitioners, whatever, to really affect change in their lives and make them the bastions of this new age of psychedelic medicine and how that could benefit?
So I can start with that briefly. As you know, the barriers to entry for psychedelic medicines into these groups are very, very high. There's a lot of misinformation. There's a lot of skepticism and stigma, particularly in the healthcare community. Most psychiatrists, for instance, do not believe any of the things that we're talking about, not because they're not true, but because they just haven't taken the time to review the literature themselves, which is how we were trained to, skeptically criticize information. That's all well and good, but we need to find a way to meet in the middle somewhere. And so Apollo, in a lot of ways, was what we created to try to meet them in the middle, because it works in from what we can tell, neuroscientifically, a lot of the same mechanisms are similar to for example, the safety that MDMA provides with a therapist present is very similar to the experience that you can have with Apollo. And so knowing that burnout is one of the greatest issues that we have right now in healthcare, where, I think it's like something like 1 in 12 surgeons have considered suicide in the last 6 months. I mean, it's crazy. I mean, you'd probably want to know that, right, before you're going into surgery. So, I mean, this is astounding, and the burnout rates are crazy. And so we're actually working with nurses from skilled nursing facilities locally, and also the entire UPMC neurosurgery residency training program are using Apollo to reduce the signs of burnout because it's something they can take with them on the go. They don't have 12 weeks to take for a medicine session or to do all the prep and things required to take away time to do that. And so that's another barrier, is the time invested in the medicine treatments is critical to the outcome you get. If you invest more time, you get more out of it. And the intention is really critical. And so, we were trying to use Apollo for these groups as an alternative they can take with them on the go, in the OR, at home with their families, in the car on the way home to transition, and things like that, so that they can, be more balanced all the time and reduce their signs of stress and the sympathetic autonomic disruption on a regular basis. But I think it is critical to, as we are gradually moving forward, educating these people. There's probably more doctors at this event that I've seen at most other psychedelic events that I've been to who are not actually working in the field actively, which is amazing. And so it is critical for us to continue to educate our colleagues, because doctors trust doctors more than anyone else. We as physicians who are enlightened to this knowledge, it's our responsibility to go to our scientific colleagues and explain to them that this is real and this is the way things are going, and it may be the greatest breakthrough in mental health that we've ever had. So let's really embrace it and do what we can to integrate it into our lives as care providers and our patients' lives just the same.
So in our protocol, where we are giving MDMA to therapists as part of their training, the FDA indicated to us that we can't just have a protocol. It has to be science. We have to do something or other science, even though really we don't care about that. We really want to give MDMA to therapists as part of their training. But the only way, because it's a controlled substance, we have to do it through protocols. And so we are using a self-compassion measure that's related to burnout as our science, as the primary outcome measure. But to further respond to your question, we don't really do science. We do political science, meaning that we have to be very thoughtful about which patient populations we're trying to help, so that when you come from a stigmatized drug, so for example, neither the psilocybin people or us with MDMA are putting addicts, treating addiction first. There's a lot of that happening, but addicts are the others. So, as far as your question, putting doctors first or treatment providers first, they're not as appreciated by the culture as veterans or women who've been sexually abused. So that's going to come, but that's not what our sort of point of contact is initially.
Would you like the last word, Gul?
Sure. I mean, I don't have as much to say because we do the science. But I would say, sort of speaking to Rick's last point about who do we care about, women have been undercared about by our patriarchal society for a long time. And the fact is that most PTSD studies are focused on the military side and less on, I mean, not all, I'm just saying, but then also the care providers that you're talking about. I mean, nurses are the most physically abused group of any profession, because we take it out on the women. And if you're interested in this topic, there's a wonderful book called Invisible Women by Caroline Criado Perez, and I highly recommend it. So that's all. I have nothing really to say about the trial design on that.
Okay, I'll just say that we have more women in our studies, but what gets the media attention is the veterans, more so.
Mm-hmm.
Yeah.
Because the media doesn't like women either.
Ooh.
That's on a good note. That's on a better note.
Okay, please help me thank our panel for being here today and answering your questions.